all the faculties to rename yourself, those who have not renamed.
Yes.
Thank you.
We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by TNFOG and AMOGS. So it's my privilege to introduce the conveners of today's webinar, Dr. K.S. Jairani Kamraj ma'am. Ma'am is the Associate Secretary of World Association for Sexual Health, immediate past President of OXY, Vice President of TAPISAR, Joint Secretary of TNFOG, and ma'am has many accolades to her credit. I welcome you, ma'am. And it's my honor to introduce Dr. Madan Kambal, sir. Sir is the consultant OBGYN and sexual health expert, aesthetic gynecologist, and also chairperson of AMOGS Sexual Medicine Committee, and also national coordinator of FOXY Sexual Health and STI Committee. I welcome you, sir, and I hand over the session to convener. Ma'am, you are on mute. Kindly unmute, ma'am.
A very warm welcome to everyone who's joined in this webinar. And I'm very honored and very much privileged to begin this webinar with a grand presence of our dynamic and very inspirational, esteemed presence of our chief guest, Dr. Sunita Madam, who in midst of a busy schedule has joined us as a very much visionary person whom she is. And we are really very happy to have her with so much of energy, dynamism, and a lot of transformation. What she's doing, we all know. And really, ma'am, you are really inspiration. And we welcome you, ma'am, for this webinar. And we have the great pleasure and honor in welcoming the guest of honors, Dr. Rajendra Pardesi, sir, Dr. Jayam Kannan, madam, who are all very much committed Foxians, who are our mentors, our leaders, to guide us and inspire us. We welcome you, madam. And I have the great pleasure and honor in welcoming our president of the Federation, Dr. Vidya, and Dr. Amaya, the guests of honors. Thank you for joining, and we welcome you, Dr. Amaya and Dr. Vidya. And we have the greatest senior faculties here from the Maharashtra Society, as well as from our Tamil Nadu Federation, who are all here with so much of knowledge to share. And it is our great pleasure to welcome you all on behalf of our Federation, Tamil Nadu Federation, as well as AMOGS. And we, both Madan and me, welcome you all the senior faculties for this webinar, which is actually bridging the gap, because we know pretty well there is a gap in the fertility treatment, because we all look into the patient to get her a baby. But in this way, there are some silent factors which are there, which is a cause and an effect, like a violence in a woman's life, which play a very important role. Because many a times, as a fertility specialist practicing more than 25 years, we never look into the violence part. We always were happy to give her a baby. But there is a silent problem that is being affected. So we just want to bring up these silent problems, the two important problems being the violence one, and another one is the sexual functions, which play a very important role. So in this webinar, we just want to have the bridges of these two, with a very important topic of the optimizing the IVF with Dr. Pratik. And all these things we are making as the bridging the gap between the violence and the sexual dysfunction and also the IVF. So we have here our pioneer, Madam Dr. Sunita Madam, who is a very much senior pioneer and a very woman who has made a lot of great achievements in the field of reproductive medicine and also in infertility in the ART in India. So I welcome on behalf of TNFOG and the AMOGS, all the senior faculties and the dignitaries. So we start with this, with a small prayer, which is a gratitude we give it to the Tamil mother, whom we worship, the mother goddess. So we start with a prayer to our Tamil mother god. So now we have the auspicious lightning of the Kuttuvilakku, which is a symbol of knowledge, purity, and unity, which invoke the light to dispel the darkness and wisdom to guide our knowledge sharing sessions. So we shall commence with the auspicious lighting of Kuttuvilakku. Thank you. So now we move on to the inauguration. On behalf of TNFOG office bearers and AMOGS, I welcome you all. And I have the great pleasure and honor to welcome our President Foxy, Dr. Sunita Tandulwakar, who is not just a leader alone, but a beacon of progressive changes what she is making in our fraternity, and her tireless efforts in advancing infertility care, her surgical excellence, and women's empowerment make her an icon we all look upon and inspire. We welcome you, madam. Madam is the
Jairani, please, no need of introduction. Please.
Yes, ma'am. Just a few lines, ma'am. Just a few lines, ma'am.
No, listen, let's meet each other. Stop this, please.
Thank you, ma'am. Thank you, ma'am.
I understand your love. I understand, and we don't need to waste academic time in introduction. So first of all, thank you so much. And now today, after long, I am joining any webinar, which is of this platform, one state along with the other state. Since I have stopped the webinars of all the chairperson, I think you got a freedom, you got an open land of India. Because these webinars used to be too many to have it. And I think our Gyan Pravaha podcast series is really making everyone more competitive, more oratory skills. They are our future leaders and they are doing it. When you are joining Tamil Nadu and Maharashtra, such a wonderful combination here. And you have the leaders of both the states with you. So this is wonderful opportunity. I think for a long I was missing some webinar. I used to join more of various organizations with Pediatric Association, with Diabetologist Association. I'm doing day in and out. But our own community and our own states, it's wonderful. And Rajendra Singh, past president of AMOGS, and Ameya, incoming president of AMOGS, I am sure it is going to be one of the best years to come. But it's so wonderful to see them. एक family बन जाते हैं हम सब. So it's like a AMOGS family and Tamil Nadu family. Tamil Nadu, I love you all. I love the culture. I'm eager to come for Rameshwar. Believe me, in all the conferences, I have gone just one night or one day, whichever is possible. But in Rameshwaram, I'm coming for 3 nights to Kanyakumari and 1 night to Rameshwar because I love the culture, I love the land, I love the mandirs, what you showed us. I don't know whether it was a Tirupati or Rameshwar, whatever these mandirs are, but they are so iconic. Even the video which you played, I have seen it before also, talking about the culture of our country, which is so rich, and that's what we enjoy. I know you want me to talk about your academics. No way. You people are doing a wonderful webinars. Keep on doing it. And I wish all the best to everyone who is joined here with the intention of Foxy, any committee or with the VP or ICOJ. I wish all of them all the best. Thank you so much. Thank you for having me and sitting in your consulting room, stopping the patient and meeting you all. After long, I am doing this. Thank you.
Thank you, ma'am. Thank you, ma'am. We are deeply honored for your presence today, ma'am. Thank you. So, madam, a small birthday wishes for you, ma'am. Though it's belated, it's sent with lot of love and affection, ma'am.
Yeah, on behalf of AMOGS,
to you. Happy birthday to you. Happy birthday to you.
Happy birthday, ma'am.
Happy birthday, ma'am.
Thank you so much. That's so beautiful. Thank you. That's what the creativity of you all here. Thank you.
Thank you, ma'am. Thank you so much for
Thank
joining us and giving your blessings, ma'am.
Thank
Over
you.
to Madan.
Thank you. Thank you once again, Sunita ma'am, for joining. It's actually our privilege and honor to have you. It's our honor to welcome the guest of honors, Dr. our own immediate past president of AMOGS, Dr. Rajendra Singh Pardeshi sir, Dr. Amey Purandare sir, Dr. Vidya ma'am, TNFOG president, and Dr. J.M. Khanna. I would like to invite and introduce respected Dr. J.M. Khanna ma'am. She is the vice president of Foxy 2018. Her credit and the managing director of Garbha Raksha Fertility Center, Chennai and Trichy. She is a great Foxian academician. I welcome ma'am, and we would love to have your blessings. Over to you, ma'am.
Thank you very much, Madan, for your kind invitation, and to my dear Jairani Kamraj, Vidya, Rajendra Singh Parshedi, my dear, one of the three musketeers of 2019, Dr. Amiya Purandare, and to all others who have joined here. I'm very happy to see Jairani coming into Foxy at a higher level. She is couple of years junior to me, just a couple of years junior to me in starting ART at Chennai. That means 30 years. I am there for the first 35 years and she's there for the first 32 years. But somehow she didn't think that she should be in the Foxy stream. But now she has decided to come in. And with her vast experience, I'm very sure the country is going to utilize her to the fullest extent as it has used persons like me, Pardeshi, and Amiya upcoming in the left side of the platform of the Foxy podium. Vidya is also slowly coming in. Madan, I think you should be coming in by next year also.
Yes, ma'am.
Yes, that's what I feel that you should be coming. And today's subject, which has been taken up, is both involving the sexual health and the failure to conceive. Both of these are very big problems. As we know, records say very clearly that 70% of the women and 40% of the men do not have satisfaction in their regular family life, marital life. That is an unwritten story which is going on. But more so in persons who are especially infertile and more so with infertile women, about which I think it's going to be very clearly brought up by Jairani, who is working in the sexual health medicine for the past 2 decades, I know. She is going to talk about both the sexual dysfunctions of the male and female also. That's what I think she is going to do, especially in infertility. And it is going to be not only infertility and sexual dysfunction, it is also going to be the IVF success, which every patient is asking for. Even though internationally we have made it very clear that 34.5% per cycle per woman is the success rate. Everybody wants to say 100% success, which today we don't agree. Robert Edwards, I remember, was saying in 1995, if anyone is able to scientifically give me the record of 100% success, I'll prostrate before him. To that extent, it's such a degree. Even nature does not give 100% success in all the this implantations which goes on in the uterus. How can we do as human beings? But still, IVF success is one topic with Dr. Pratik Tambe, along with Kalpana, infertility is also going to take it up. I wish this CME a great success and all the people who are trying to ascend up in the Foxian ladder. We all welcome you with open hands. I won't say with folded hands. We welcome every one of you and take this lead of India to the highest level. All the best for all of you. Thank you very much. Please go ahead.
Thank you, ma'am, for your kind words. Thank you so much.
Thank you, ma'am. Thank you for your kind words and blessings, ma'am. Thank you, ma'am. So I'm very happy and honored to welcome Dr. Rajendra Singh Pradesi, sir. Sir is a very great person, a very soft person, and a very dynamic but very strong but very soft person. Thank you so
It's
much for
okay,
joining us, sir.
Jairani.
Sir is the
Yes,
past vice
we can
president
skip
of
that. Jairani,
Foxy.
we can skip that.
Sir,
Good evening, everybody. Respected chief guest and our beloved president, Dr. Sunita Tandulwarkar, ma'am. Guest of honor, Dr. Ameya Purandare, Dr. Vidya Prabhakar, Dr. J.M. Kannan, and TNFOG office bearers, Dr. Vidya Prabhakar, Dr. Sampat Kumari, amongst office bearers, Dr. Kiran Kurtakoti, Dr. Bipin Pandit, Foxy chairperson, Dr. Kalpana Balamurugam, and friends. First, I wish to congratulate Dr. Madan Kamble and Dr. Jayarani Kamraj, conveners of this webinar, for organizing such an academic feast, basically jointly with AMOGS and TNFOG. As Dr. Sunita told rightly, it's a really jointly nice program. From my tenure as AMOG president and Dr. Kiran Kurtakoti, we have encouraged this association of AMOGs with TNFOG to exchange our ideas, hence for the betterment for women's health. I cannot forget the warm hospitality of Dr. Vidya Prabhakar, Dr. Sampat Kumari, Dr. Ramana Devi, Dr. Jayarani, recently in the TNFOG annual conference at Salem. I think Dr. Madhumita Karthik is there in program. She advised us to take Perumal silk. We buy Perumal silk from Salem. My better have enjoyed this shopping also. With the galaxy of speakers and faculty like Dr. Jayarani Kamraj, Dr. Madan Kamble, Dr. Pratik Tambe, Dr. Kalpana, and panelist chairperson, this is going to be a great event. I wish every success to Dr. Jayarani Kamraj for her future endeavor as chairperson of Violence Against Women Committee Foxy. Then Dr. Pratik Tambe in his future endeavor as ICOG Secretary Foxy, and to Dr. Madan Kamble also in future, as Dr. Jayam Kannan told. I wish every success to this webinar. Thank you. Thank you so much for inviting me. Jai Sri Ram.
thank you, sir. Thank you so much.
Thank you, sir. Thank you. Yes, it's my honor to invite and introduce Dr. Vidya Prabhakar, ma'am. She is the very cool and humble person from TNFOG, currently heading the presidency of TNFOG, also past president of Salem Society.
Thank you. Thank you
Yeah.
very much, Dr. Madan Kamble.
We welcome you, ma'am.
Thank you very much. Yeah. So thank you very much, Dr. Madan and Dr. Jairani, for having me here today in this wonderful webinar of two big societies, two very academic societies like AMOGS and TNFOG. And I'm extremely privileged to be here with Dr. Sunita Tandulwarkar, ma'am, our beloved president, as the chief guest, and Dr. Rajendra Singh Pardesi, sir. My God, sir, how can you remember so many people's names and everybody's name you just rattled off and remembered something or the other about everyone. Thank you very much, sir. And Dr. Ameya Purandare, sir, and Dr. Jayam Kannan, ma'am, and for all those wonderful insights that she gave. And today's topics, I feel, are absolutely innovative and really important, actually, the need of the heart, because we are not addressing the silent struggles that are happening. Because of the infertility, there is so much of frustration, and probably that leads to sexual dysfunction and a lot of dissatisfaction, and probably ultimately to violence as well. So I think you're combining all these three things, like sexual dysfunction, violence against women, and optimizing IVF success. My God, I think that's a wonderful topic to have. And I must really congratulate Dr. Madan and Dr. Jairani Kamraj, ma'am, for being so hardworking. You people are really amazing, so hardworking and very prompt. Both of you all are immediately. So wherever what has to be sent, it has to be done immediately. So prompt and hardworking. I wish both of you success in your careers. Thank you very much for having me here.
Yes, thank you, ma'am.
Thank you, Dr. Vidya. Thank you so much. I am very honored and very much privileged to introduce and welcome Dr. Ameya Purandare, the young, dynamic, as well as a walking encyclopedia person who is really great with so much of knowledge, we look upon and admire. We welcome you, Dr. Ameya. So, sir is actually the Senior Vice President of AMOGS 24-26, and he is the Joint Secretary of FOXI 2019, and he is the Chairperson for the Food and Drug Medical Surgical Equipment Committee between 2015 and 17 in FOXI, and he is the Joint Clinical Secretary of
Jairani ma'am, everybody knows me, so
yes, sir. But still, it is you are the guest of honor, so we are so happy to welcome you.
Thank you
sir.
so much
Over
for
to
those
you.
thank you so much for those kind words. I think I bring you greetings from both AMOGS and FOXI, and Vanakkam to all of you. Most importantly, I think that the trinity of FOXI, AMOGS, and TNFOG, I think is probably one of the strongest collaborations in the country. Not only for the academic collaboration, but also the community work that we all put in, and also the fellowship that we have. I would really like to thank Dr. Jairani Kamraj and Dr. Madan Kamble for organizing this important scientific webinar and bringing these three organizations together to give very important knowledge about these very crucial subjects. The WHO has defined health in various ways, in which sexual health is an important component to finally classify that a person is healthy and not diseased. In the recent survey carried out by WHO, they have identified three important challenges in the years to come as far as fertility is concerned. They are stress, sugar, and sex. And I think that is the importance of sexual medicine in today's world, especially with respect to reproductive medicine. I think that is why the sexual committee is very important. The work done and the knowledge and awareness dispensed by it is also extremely important. And congratulations to both of you. I pay my respects to our beloved President, Dr. Sunita Tandurwalkar of FOXI, Dr. Vidya of TNFOG, my mentors, Dr. Jayam Khannan, who has always encouraged me in all my endeavors, and Dr. Pardesi, who is like a father figure to all of us in AMOGS. We are very blessed to have an extremely distinguished faculty this evening, and I'm sure that all of us will learn a lot through this webinar. So thank you once again, and wish you all the best.
Thank you, Dr. Ameya. Thank you for your time and words. Thank you so much.
Thank you, sir. Thank you.
So we'll move on to the academic session. Over to you, Madan.
Yes. Thank you once again, today's chief guests and guest of honors. And I welcome all the presidents and secretaries of societies of TNFOG, Madurai, Nagarkoil, Erode, Coimbatore, Vellore, Tirupur, and Oxy, and also AMOG societies, Kolhapur, Jalgaon, Dhule, Chandrapur, Jalna, Udgir, Bhandara, and Aklus. I welcome all the delegates also who have joined today. Let us start the scientific program, our first session. For the first session, we have esteemed chairperson for this session, Dr. Jitendra Gumre sir, Dr. Shweta Manwatkar, and Dr. Manoj Aglave sir. May I have CVs? Dr. Jitendra Gumre sir, he is the senior OBGYN and president of Dhule OBGYN Society, and also head of the department at Bahusab Khire Medical College, Dhule. Dr. Shweta Manwatkar, he is obstetrician gynecologist, director, Manwatkar Hospital Nursing Home at Chandrapur. He is faculty at many conferences and also work as faculty member in many conferences and AMOG Chandrapur. Welcome, Shweta ma'am. Dr. Manoj Aglave, who is the currently honorary secretary of Bhandara OBGYN Society. I welcome you, sir. And I'm handing over the session to the chairpersons. And I request chairpersons to introduce our speaker. Yes. Anyone joined from chairpersons?
Not yet, sir.
Okay. Okay. I will introduce ma'am.
Hello,
Our
sir.
own.
I am there.
Oh, yes.
I'm Dr.
Madam
Shweta
has joined.
Malwar.
Shweta, madam.
Oh, please, ma'am.
Yes.
Please introduce ma'am.
Dr. Jayarani Kamraj ma'am is MBA DGO, and she is a senior consultant of reproductive medicine, infertility and sexual medicine, director Akash Fertility Center and Hospital, Chennai, and she's a associate secretary, World Association for Sexual Health, immediate past president, Obstetric and Gynecological Society of Southern India, vice president Tapisar, and Joint Secretary TNFOG, Advisory Council member World Association for Sexual Health, Joint Organizing Secretary ISAR 2015, member of Board of Studies Dr. MGR Medical University, lifetime member of OXY, lifetime member of American Society for Reproductive Medicine, and member of European Society of Reproduction and Embryo. She has many awards and medals. Best Doctor Award by Dr. MGR Medical University, Chennai, Rajmani, Jankiraman University, first prize in gynecology and obstetrics, Dr. Veda Malyan and Domain, gold medalist in MBBS in Obs and Gynec, and Dr. Anantachari Prize for being university first in medicine, gold medal in DQ, and Dr. MGR University exam, awarded the Woman of the Year 2010 by the Lions Club, achievement of main service award by Ex-Nora 2010, Mega TV Women Achiever Award in 2011, and Nalam Hospital Women Achiever Award in 2011, Best Paper Award for Sexual Dysfunction in because infertile women, AFOS 2016 in South Korea. We welcome you, ma'am, for your talk. We are waiting.
Thank you, Chairperson, for that elaborate introduction. I'm humbled and honored with your introduction. I'll move on to the topic. Can you see my screen?
Yes, ma'am.
It's full slide, Sahiti?
Full screen only, ma'am.
Thank you. So, thank you, Chairperson. Thank you, AMOGS and TNFOG, for giving me this opportunity to speak on this wonderful talk on a very important aspect, that is the I think my slides are not moving. Yeah, I have, right. So it's the silent struggles, which is that is an interplay of the infertility and violence against women. So this silent struggles, so when you look into the infertile women, when she comes for the treatment, so we always look upon the treatment as success, but there is a part inside her which is very much silent in this struggle. So to get the pregnancy, she has a lot of struggle, and that struggle is not through her treatment, but also through her intimate partner. So this struggles is a very important part in the women's life, especially in an infertile woman. So we have to look into this, a very important strategy when we are planning any treatment. So that is why we bring this part into this discussion. So this violence, it could be a cause of the fertility, because when a woman is based with a violence, definitely she has a lot of problem to get a pregnancy, or the fertility is a question. And same way, it can be a effect of her infertility. So the violence is a very important basic thing which we should look upon, which is a silent struggle a woman go through when she faces a infertility issue. When you look upon globally, we know pretty well 10 to 15% of the married couple are infertile. Of course, globally, 1 in 6 couples suffer through infertility. But when you look into the WHO data, the globally 1 in 3 women experience their physical, sexual violence with an intimate partner violence. That is, in her lifetime, every third woman goes through this experience, either a physical or sexual intimate partner violence. And very pathetically, if you look into the Southeast Asia report, 30 to 50% of the women attending the infertility clinic experience some form of intimate partner violence. A very important study from Tamil Nadu revealed 32% of the infertile women reported emotional abuse very much linked with infertility. Why this is happening? So when you look into the infertility, it is a significant risk factor for the violence against women, particularly the intimate partner violence, which is very much prevalent among this infertile couple. And studies shows that infertile women, especially from a low income group as well as the middle income group countries, experience higher rate of physical, psychological and sexual violence compared to fertile women. This violence can stem from the cultural beliefs that women are the one who are to be blamed for the infertility, and that is mainly leading to a lot of social stigma and emotional distress and even of physical abuse. So how this is interrelated? If you look into the violence, in the infertility, there is an increased vulnerability in the infertile women, because infertile women, when they face an infertility, they are often perceived as having failed to fulfill a core expectation within their marriage as a women, because for them, a pregnancy is a natural phenomena which is not getting corrected, or which she is not able to achieve, and that throws her into a vulnerability, making the society gets her into some forms of violence. So it is a core expectation within the marriage which she fails to fulfill, throw her into a vulnerability of the risk of violence. And when you look into the lot of cultural factors, because in almost many cultures in the world, infertility is seen as a women's problem, and the societal pressure and expectations can lead to violence and abuse. And importantly, the patriarchal society where the men dominated world, the women are often solely blamed in a male dominated cultures. I think all the infertility specialists who are here there know that even when a man has a problem of an azoospermia, it is a woman being blamed because of this infertility. So we all know the blame comes to women because of the patriarchal society. So definitely infertility is not just a medical issue alone, but a social and an emotional crisis for a women in these patriarchal settings. And definitely we have to address this violence, because without addressing the violence, fertility treatment success is also very much limited, because a trauma-informed women-centric approach is always an essential for the ethical and effective infertility care. So how this violence is impacting the fertility? Because when you look into the women, when she faces some form of a violence in the family life, either in the marriage or in the family or in the intimate partner relationship, then she's thrown into a form of fertility issues. Because when she suffers through domestic violence, which may lead to a stress, trauma, and even it can cause a lot of reproductive tract infections or physical injury, which may lead to an infertility. And sexual violence, which could be a sexual abuse or a rape or even a PID or an STI caused by the violence, may cause a lot of problem related to the fertility. And that causes a lot of fear in the intimacy, causing a lot of sexual dysfunction, which may be predisposing her for a fertility issues. And the emotional abuse, like the verbal insults, pressure to conceive, threats from the family, from the relatives, from the mother-in-law, father, everybody making her go for a lot of emotional stress, which may lead on to her fertility issues. And also the men threat of the abandonment of the marriage, polygamy, all these things makes her go for a lot of emotional stress, which may cause or it may even lead to a fertility issues. And forced decisions about the contraception, because many a times they are forced for a contraception even when they are willing for a fertility, because we come across many couple, they want to have a contraception, but in the outside world they are shown as married 5 years, they don't have children, but they'll be on a contraception with the women fails to, which she cannot disclose to any of her elders, and that itself will make her go for a fertility infertility in stress. All this causes a lot of problem in these women, and forced abortions, and almost many a time the treatment also. All these things has an impact in her fertility. So violence definitely has a physical, emotional, sexual and financial causes, and this either cause or even the worsen the fertility. And even in sometimes in the fertility clinics, this is almost nobody knows about it, and even sometimes there will be the abuse will be normalized. And when you look into the infertility, it risks the violence. How it has a lot of psychological impact in the infertile women. infertility itself can cause significant psychological distress and add stress to the violence, further exacerbate these issues, leading to a depression, anxiety, low esteem, and also a low image or self-image being lowered, and even they go for a depression. And even a lot of studies showing that infertile women are more likely to experience physical and sexual violence from their own partners, and a lot of emotional abuses can definitely is making the women go for a lot of stress and distress. And thus the violence is also when it has been diagnosed as an infertility, either the women could be a cause or the men could be a cause. When you are diagnosing an infertility, that itself triggers the violence. So the fertility treatment often acts as a trigger point for the abuse, and also the financial pressures which arise from the treatment worsens this abuse. And when the women faces a failed cycles, that disappointment also have a lot of impact in her physical violence, and a lot of blaming and a lot of physical aggression which happens in the family with a mother-in-law, with a husband, all causing a lot of problem in her physical way, causing a lot of violence. And cultural practice, many of them, the abandonment, threatening of the second marriage, a lot of dowry harassment, all these things can be triggered by this infertility diagnosis. So all these factors have been triggered when a woman faces a infertility. How and what it causes in her life? Definitely this causes stress, which indirectly leads to a cortisol elevation, increase in her obesity, increase in her sedentary lifestyle. Depression itself can cause a lot of problem in her hormonal milieu, causing a disrupt of ovulation, irregular menstrual cycles, and impaired hormonal imbalances, all causing a disruption in her ovulation, which itself may lead to infertility. And the fear that a woman goes through when she faces with a difficulty in getting pregnant, and lot of social judgment also play a role, which causes her to delay in seeking the help. She makes this very much fearful to disclose the difficulty. That also happens in many women, especially when they go through a sexual dysfunction, a vaginismus, or a painful sex. All these things make her go for a fear that also play a role. And also isolation. They always feels that their access to the healthcare is very much isolated because of this fertility impairment. That is all very much common. And sexual dysfunction due to the trauma, mainly the timed intercourse or a sexual participation among them during the ovulatory phase, all this makes her go for a mental stress, which may lead on to sexual dysfunction. So the consequences, yes, there is a lot of impact in their mental health, the physical impact in their social life, and also it has an impact in the treatment part, because many times because of the stress and anxiety, the depression, she goes through a problem that she may even stop her treatment. Many times the violence can disrupt the infertility treatment and make it more challenging for the women to access and benefit from the healthcare services. So all these factors, the violence gets all the women goes into an anxiety, post-traumatic stress disorder, and even a lot of mental health issues. So these are the consequences. So infertility itself can cause a lot of pressure, especially the social pressure. It leads to violence, and that leads to stress and injury. Either it could be a physical or a mental or a psychological injury, causing a fertility and even worsening the fertility. And that itself will trigger a violence. So it becomes a vicious cycle, the infertility itself. And also because of the infertility, they go through violence, and because of the violence, they go through a worsening of their fertility. So the violence definitely play a major role in causing the infertility, as well as the effect of the infertility. So what the evidence says, it is almost, we are talking about violence, which is very much new, but still, when you look at the global evidence, there are so many studies which says what they reveal is, in a evaluation of a systematic review of the global evidence from Stellar et al., they say that the says that the increased risk of intimate partner violence in the low and the middle income group countries, and they are based on a 21 quantitative studies, states that there is an increase in the intimate partner violence among this low and the middle income groups. And even a systematic review and meta-analysis from PMC 2022 states that there is a lot of increased incidence of the domestic violence in the infertile women, and that shows they are more exposed to all form of domestic violence like psychological, sexual, economical, and physical, with lot of factors which may lead on to increased infertility issues. And there are some studies like when you look into the global studies where they're assessing the qualitative healthcare studies from one study from the Beijing, what they said is the women attending the ART clinic, they said that infertility intensify the risk of psychological intimate partner violence like stonewalling, diverse threats, refusal to support the ART treatment, and also has a lot of impact in their cultural norms and gender inequalities. That is the report from the Beijing. And Egyptian studies also said that the women faces many high level of risk and violence, up to 50% partner violence, especially from the who belongs to a lower income group and also the lower education. It predisposed more for their violence. And even in Iranian studies state that higher prevalence of violence is noted in the women or in the couple with an infertility. They have a higher risk of having a domestic violence, and they always have an issue related to the domestic violence. What about an Indian study? There is one study in Indian study, Catol study from Nagpur. They said that there is a high prevalence of spouse violence across emotional, verbal, physical, and especially sexual domains in the women facing the infertility, with the women ranging age from 18 to 49 facing the infertility. In another study in Bangalore in 2018 by Satyesan and Satyanarayana, surveyed nearly 30 women with primary infertility. What they found out is 47% reported intimate partner violence, and intimate partner violence was linked with poor marital quality, higher psychological distress, and lower resilience. And there is one more study from Bangalore. It's a psychiatric comorbidity associated with intimate partner violence. What they found out is elevated level of domestic violence, stress, anxiety, and depression when compared with the fertile controls. They have studied in infertile women. This is more common in infertile women. So almost all the studies of the Indian studies says that there is an increased rate of domestic violence, an increased associated stress, depression, anxiety, and higher psychiatric comorbidities linked with IPV in the infertile women. And also there is sexual intimate partner violence and a high risk of fertility outcomes is more in their reproductive behavioral consequences. And all the women are having a lot of clinical implication interventions are needed for this women, especially related to the domestic violence and the IPVs. So how we are going to address this issue? The first thing is we have to address by raising the awareness, and secondly, we have to provide support services for this affected women. And also we have to develop a prevention programs to prevent this violence being happening. And also we have to promote safe spaces for this crucial problem which is prevalent among the infertile women. How we have to do that? That is a very important one. What we gynecological should do, because the problem is with us, we are looking into the infertile women. So it is our important role, a clinical ethical leadership which we have to take a role to screen these women and identify the violence. That's very important. So we have to integrate a routine screening for this intimate partner violence in our fertility clinic along with a proper history. So when you are taking a history for these women, we should include this routine screening for this intimate partner violence. So we use two validated tools like HITS and WAST. I'll be talking about this in the next slide, and which should be done in a confidential setting. So we have to do this, screening and identification of this violence in this couple. Second, we have to recognize the emotional and the psychological and the physical signs of abuse in this women, and we have to modify care approaches for this women, especially with the trauma, either by a gentle communication, a consent seeking, and emotional validation, which is very importantly we as a gynecologist should do. And thirdly, we have to do a counseling and referral services, especially we have to collaborate with the psychologists, psychiatrists, and social workers, and also with the NGOs, and also with sometimes with the legal aid teams to give them a support and proper counseling and even guiding them to come out of this violence. And importantly, we have to give them a very safe atmosphere. That also very important. And we have to take a separate sessions to the partners, because sometimes it is very difficult to take the session along with the partner. So couple counseling, once we do a couple counseling, we have to do it very safely. We have to address the marital communication and the expectations around the fertility and involve male partners in education, shared infertility responsibility. And we have to plan and make a proper documentation or maintain a confidential medical records of the abuse disclosures. And sometimes we have to help them to protect them under the Domestic Violence Act 2005. So these are the main important gynecological role that we have to do. So what is this KITS and VAST, which we as a gynecologist should use? Because these are all the screening, they are all a screening questionnaire which are given to the fertility and infertile women. When you're taking a proper history, we have to go through this questionnaire. This questionnaire has 4 important things like hurt, insult, threaten, and screen. This is a quick self-reported screening tool to assess the frequency of the abuse. So we should physically hurt her, insulted or talked down to her, threatened her, or screamed or cursed at her. These are the 4 important points we should ask her in the questions. And this will give a scale, like from 1, it should be never or no violence, and 5 is more often, that's frequently. So the total score ranges from 4 to 20. If the score is more than 10, that suggests the possible IPV, and that indicates a need for further evaluation and referral. So along with the general history taking, we must include this questionnaire in all the women with infertility. And second is the VAST, that is the Women Abuse Screening Tool. All these things have been given by the WHO. So we should adopt in our routine practice to take these screening tools to assess these violence in these women. So this is a more detailed assessment tool that helps to evaluate the emotional and the psychological abuse and the physical abuse in this intimate relationship. There are 2 formats. One is a short form where we have to ask her, do you and the partner argue a lot? And do you feel frightened by what your partner says or does? If she answers, suggest a concern, or if she answers yes, then we have to move into the long form where we have an additional 8 items which can give us an idea about the conflict, resolution, emotional distress, and control and intimation, and the physical violence. These are the other items which is included in this long form of VAST. So with this, we can come to a scale where the number 1 is no tension, number 2 is little tension, and number 3 is the maximum she goes for a stress. And the interpretation, if the score is more than 13, it often there is a risk of intimate partner violence. The tool is a non-confrontation suitable for any easy, sensitive gynecology or infertility setting. So all the women, even in the gynec OPDs as well as infertility settings, we must have this assessment. But one thing we have to keep, all the questionnaire says that it should be given in privacy and confidentiality. It should not be given when the couples are there together. It should be given separately to the women so that she can answer this question in confidence. That's very important. And never screen the women in the presence of the partner. That is very important. And these are all things will help you to assess the intimate partner violence as well as the abuse, what she has going through, and the severity of the problem. And this will help us to refer her to the psychologist or the legal aid, what we can give, or even we can shift her to a shelter to make her safe in the safe way. So it is our clinical responsibility in the fertility settings to do this for all the patients who come to our clinic. The WHO even recommends for all the gynec setups, the same thing we can use for the infertility clinics, and we have to do a confidential counseling space for this women to disclose this abuse, and then we can plan a counseling for a safe and appropriate care. And even we have to recognize the signs of the abuse and give her a proper referral and guidance. So what are the solutions? Yes, we have to train our fertility care providers about this intimate partner violence. It should be a multidisciplinary approach. We should include the mental health professionals and also the social workers to work help these women to come out of this violence. And we have to give them the legal literacy or the protection laws, because we have a strong laws like Domestic Violence Act of 2005 in India, which is almost a very good law. We have to give them a legal advice about all these things and guide them if they're really suffering through the violence, and also empowering women with education and support group and financial dependence is also should be the norms. And definitely there should be a societal solution. It is not only the clinical solutions what we give, it also should be a societal solutions. Like we should have a public health campaigns where we should use the mass media to raise the awareness that infertility is a shared issue and violence is never justified. We should be very strong about it, and we have to promote the positive narratives even for a woman, because many times when the woman fails to conceive, even with a lot of IVF failure, we should counsel her of a positive narratives of a child-free woman. She can have a child-free life. She can also have an adoption. She has to be supported in the mental health when she fails an IVF. All these things has to be given as a public health campaigns, and we have to educate in a community. Like we have to target the families like the mother-in-law or the sister-in-law or the elders or the others who were torturing her with so much of violence, with abuse, with all the abuse words. So we have to give them a community education, especially the family oriented, target oriented, especially the family elders has to be given the proper advice and education. And we have to create awareness for the rural workers about this detection of IPV signs in the women who are undergoing the reproductive health consultation. So the ASHA workers and the ANMs should be counseled or should be educated about this abuse signs and also the signs of this to be checked in the reproductive medicine people. So even we should involve the men's engagement, educate men about the knowledge about fertility, and tell them that there also could be the reason, because many times even when the men is a cause for the infertility, the women suffers the violence. So they has to be educated. It should be a couple oriented counseling and couple oriented treatment that will make them understand the basics of this cause for the infertility, that will give them a better outcome in their violence problem. So psychological toll, definitely they have to be emotionally supported. That will help them to have an improvement in the marital bond. So very important, we have to shift this cultural shift from the patriarchy to the partnership. Let's all break the silence, encourage the survivors, because sometimes they are very scared to come out of this problem. They are very scared. They don't want to share the experience, but we should encourage them to share their experience in safe platform. That will help the other people who are suffering through this violence to come out with a positive way. So that will help the support the survivor-led groups, which will create, we have to create a support survey group, which will be helping them for the other people who are suffering through that to come out. And we have to even add on a storytelling initiative, especially in the blogs and in the social media, and also create a helplines for them to have a supportive system. And very important, we have to redefine the womanhood, because many times the women feels that only her worth is motherhood. But you have to educate her that she should understand herself as a woman. The women is not it's not worth of a motherhood. She's more than a motherhood, that she should feel her worth. That's very important, especially a very important role in the education, career, and leadership. That should be the women's identity that she has to create. That's very important. And of course, sometimes we have to debunk the myths around the infertility, which will definitely have a very important challenge, which can make a lot of social reforms and religious reforms. Many times the norms in the religion, the social, which justify this abuse, the name of lineage, karma, and fate, has to be shattered, has to be changed, especially in the myths which avails around the fertility. So we have to do as a gynecologist, we know pretty well there is a strong global association between the violence and the infertility in the infertility setup. So infertility and subfertility moderately increase the risk of IPV, and there are a lot of forms of violence in that, and infertility itself is a risk factor. So we have to look into the clinical and the social and cultural factors, especially in the low income group and also in the low medium economical factor couple. There is always a risk factor. So we have to have a routine IPV screening in infertility and the gynecological clinic, and a multidisciplinary care team like psychologists, social workers, gynecologists, and legal support has to be given. And we have to have a culturally sensitive support system addressing the gender norms and the stigma. So we as a specialist here, fertility specialists, should know that IPV screening incorporate during your history taking, especially when there are symptoms like pelvic pain or treatment for non-compliance. That should be a first line support. Use this WHO lives, that is listen, inquire, validate, enhance, safety and support. That should be the first line support you should use. And mental health integration, refer the proper counseling to a psychologist or a psychological professional. Has to be taken care when they come across a lot of mental health integration, which are very mandatory in your counseling. And educate and train your staff in implementing the preventive measures and also training them to identify the IPV and the sexual violence in the women. And we have to have a care integration in your treatment schedule, in your fertility protocol. Mainly, you have to screen them, properly educate them, and properly treat them, and even sometimes refer them for the psychological care. And very importantly, the survivors should feel safe when they disclose and the decisions. There should not be any forced reporting. They should feel that the patient, they should have their own autonomy. So these are all the things that we must look into our clinical practice, which will definitely help build up a good bonding as well as a good and strong women who can face this infertility, which is already a very stressful one, in a better way rather than with a depressed way. So very important, we have to educate, empower, and make the women know that the infertility treatment will remain incomplete unless we heal the hurt women carry within. The women carry so much of hurt. It is up to us to heal the hurt. No uterus can flourish in fear, and no family should be built on force. So this is what the final message I just want to give as a fertility to all the fertility specialists here who are looking into this webinar. So thank you so much for your kind and patient listening, and I'm open for any questions. Thank you so much.
Thank you, ma'am. Thank you, Dr. Jayarani Kamraj, ma'am, for the informative and engaging session. That was a thought-provoking and well-delivered talk. I especially like the point that raising awareness is very important. Provide support service, prevention program, promote safe spaces, then screening and identification of the victim, then trauma-informed care and counseling and referral. We should refer the couple or the victim. Then it's an vast, you informed about the scoring system. Then we have to educate, empower, and engage the women. And then infertility, the take-home message: infertility treatment will remain incomplete unless we heal the hurt women carry within. No uterus can flourish in fear, and no family should be built on force. So we have to encourage those who are victims of violence to seek help and to know that they are not alone. They should not be ashamed, and as we as a society must take action. If we don't act now, more people will live in fear every day. We can only hope that this issue will be resolved one day, and I hope it will be sooner rather than later, because no one deserves to be treated this way for such insignificant reason. And your talk was so elaborative, and it was nice to hear from you, ma'am. And your work beyond this is very much appreciable. Thank you very much, ma'am. And also, I would like to thank TNFOG and AMOGS office bearers and Chandrapur OBGY Society for giving me the opportunity as a chairperson for today's webinar. Thank you once again, ma'am. Let's now move ahead to the next session.
Thank you, ma'am. Thank you so much. So we are moving on to the second session. Can I have the CV of the chairpersons for the second session? I have the great pleasure and honor to welcome the chairpersons of this second session, Dr. Nagankar, who is the president of the Kolhapur OBGYN Society, Madam Dr. Anita Sanjay Bhavishkar, who is the honorary secretary of the Jalagan OBGYN Society, and Dr. Supriya Jagdip, who is the honorary secretary of Udgir OBGYN Society. Can I have the CVs of Sir? Yes. Sir is Dr. Nagankar. He is the practicing gynecologist and laparoscopy surgeon since 29 years. He is the president of the Kolhapur Obstetric Gynec Society. We welcome you, sir. And I have the great pleasure and honor in welcoming Dr. Anita Sanjay Bhavishkar, madam. She is a consultant obstetrician gynecology from the Krishna Hospital, Jalagan, and her special interest is high-risk obstetrics, and she is currently the secretary of the Jalagan Obstetric Gynec Society. We welcome you, Anita, ma'am. And I have the great pleasure in welcoming Dr. Supriya Jagda. Madam is the working consultant gynecologist at the Mangalay Hospital and Maternity Center. She worked as a SRTR hospital in Ambigoy. She has presented papers in AMOGS and Sholapur AMOGS in Shridi. And she is the organizing joint secretary of the AMOGS Zonal Conference Uday of 2024. And she has been awarded the Yuva Gynecologics Award in AMOGS 2025 Chandrapur. Over to you, Dr. Supriya, and the chairpersons. Kindly introduce the speakers, and over to you.
I'm happy to introduce Dr. Madan Kamble, who is consultant OBGYN and sexual health expert. He's expert in aesthetic gynecologist. He's chairperson AMOG Sexual Medicine Committee. He's national coordinator FOXY Sexual Health and STI Committee. He's past secretary and president of Akuluz OBGYN Society. He got awards of wonder, Amoxian Award in 2022 and Legions of Gynecology Award in 2024. He has many publications, and his Amox focus on sexual health that was published in 2023. So I'm happy to introduce the sir, and over to you, sir, for your topic.
Thank you, sir. Thank you. Yeah. Shall I share the screen? Is it visible?
But it's not
Yes,
full screen. Make it as full screen. Yeah, now it's fine.
Okay. Thank you, chairpersons, for the kind introduction. And thank you, TNFOG, for associating with AMOGS. As Madam has very well highlighted many aspects of infertility as regards the violence. I'm going to discuss a related thing which is very useful in our day-to-day practice, a practical approach to the sexual dysfunctions in infertile couples. Being a gynecologist, we almost more than 95% people from us practice infertility. And in our daily practice, we face many cases of sexual dysfunctions in infertile couples. That is why it is the purpose of presenting this topic to have just idea or knowledge regarding the basics of sexual dysfunctions, sexual history taking, and how to manage such cases. That is the main motto of this topic. Let us understand something about the sexual dysfunctions, which are the dysfunctions, common dysfunctions, and how to tackle with them. Sexual dysfunction is nothing but the alteration in any phase of sexual response cycle. There are 4 phases of sexual response cycle, and problem at any phase cause the sexual dysfunction. That dysfunction which is preventing the sexual activity. Looking at the prevalence of these dysfunctions, almost it ranges from 10 to 52% among the men and 25 to 63% among the women. And many times this changes in the mental health status, like depression, anxiety, stress, which often leads to formation of these sexual dysfunctions. Then let us understand about the magnitude of this problem. It's too big problem. Day by day it is rising, and we have to take this seriously about this magnitude. And one common denominator between the male and the female factor is the inability to have the adequate sexual intercourse. There are so many causes or factors. Stress factor is there, incompatibility factor is there, and most important is the psychosocial factors which are causing these dysfunctions. At the same time, there are so many myths and misconceptions about this in the society, and we have to look for this, and we have to address about these myths and misconceptions which are to be removed from patient's mind, because these are going to affect this aspect of infertility and the treatment. The clinical entity of apprehension about the potency, that is which is commonly held in most of the Indian subcultures, that is the about the masturbation and night emission before the marriage, which result in loss of potency. We know this is the myth and this is the wrong statement, and there are so many myths like about the masturbation. Masturbation is considered responsible for shrinkage or sideward curvature of the penis and also for the watery semen. And also there are some exaggerated apprehensions about the first wedding night, that there must be bleeding on the first wedding night. That is also one apprehension. And many times there are so many myths about the size of the penis that are to be removed from the patient's mind, and we have to address them well and remove the myths. Then how to classify these female sexual dysfunctions? Yes, I will only outline the classifications. There are two classifications. Old criteria is DSM-4 criteria, and the recent criteria is according to DSM-5. In the old classification, female sexual dysfunctions were classified into main four types. That is the sexual desire disorders, arousal disorders, orgasmic disorders, and sexual pain disorders. Sexual desire disorders were again of two types: hypoactive sexual desire disorder and sexual aversion disorder. And sexual pain disorders were again of dyspareunia and vaginismus. But in the recent classification of DSM-5 criteria, the first two types, that is desire and arousal, are clubbed together to form sexual interest arousal disorder. Orgasmic disorder is kept as it is, and the sexual pain disorders are termed as genitopelvic pain penetration disorder. Then, what is the relation of sexual dysfunctions and male infertility? Psychological concerns of infertility may underlie the sexual dysfunction. Also, there are some medications which are affecting this dysfunction or causing the dysfunctions as a side effect of medications. For example, antipsychotic medications are there, antihypertensives are there, like beta blockers, SSRIs there, which can cause sexual dysfunctions. And also, any sexual dysfunction is the proxy of general health. For example, erectile dysfunction is also a proxy of general health. That is, that person might have any cardiovascular event in future. That is why we have to be very cautious. In infertile men, hypoactive sexual desire and lack of sexual satisfaction are the most prevalent types of sexual dysfunctions, which range from 9 to 70%. And amongst these, erectile dysfunction and premature ejaculation are the very common dysfunctions whose prevalence is 1 in 6 in fertile men. Also, orgasmic dysfunction is also common with the prevalence of 1 in 10 in fertile men. And as far as this magnitude is considered, in 1995, there were 152 million men worldwide reported to have ED, and it was proposed to be projected to increase up to 322 million in up to 2025. Such a alarming rise in the cases is going on, and that is actually a worrisome problem. With erectile dysfunction, without a history of any cardiovascular disease, he has 45% increased risk of having a subsequent cardiovascular event within the 5 years, as compared to the patients who are associated with other high-risk factors like smoking, diabetes, depression, hypertension, and heart disease. ED, again, it can be a psychogenic or organic. Let us understand in short what is erectile dysfunction and what is premature ejaculation. Erectile dysfunction, it is the male sexual dysfunction, which is typically characterized by marked difficulty in obtaining an erection during the sexual activity. Also, maintaining an erection until the completion of that sexual act, or decrease in the erectile rigidity. That forms the definition of the erectile dysfunction. And ejaculatory dysfunction may be premature ejaculation, delayed ejaculation, retrograde ejaculation. Now, what are the causes for these ejaculatory dysfunctions? Ejaculatory duct obstruction may be there. Some physical causes like spinal cord injury, radical prostatectomy, pelvic trauma may be there. And again, some comorbidities like diabetes mellitus, multiple sclerosis, Parkinson's disease. Also, it may be secondary to some medications, and some neuropathies may be responsible for this ejaculatory problem. Then question arises how to evaluate such cases. First and most important is the history taking. History taking should be always comprehensive. We all know how to take history since the undergraduate days. But as far as this subject is concerned, we have to focus more on the sexual history taking. Complete history should be taken along with our routine history. Sexual history should be in detail, like asking about the symptoms and going into the details of symptoms like onset, duration, progress, any associated factors should be asked, any comorbidities should be asked, any treatment of medications, history of medication should be asked. Associated risk factors should be assessed for that. Any cardiac disease, any hypertension, diabetes, thyroid disorders. There may be some addictions or use of recreational drugs which can affect this which can cause this problem. And some medications, as I said previously, are many medications may cause the sexual dysfunction. And last is the physical examination. Physical examination is very much important in both the partners, male and female, should be thoroughly assessed along with general examination. The examination of genitalia and the complete physical examination should be done. Then hormonal evaluation. It is very important to evaluate the hormone levels of prolactin, total testosterone, free testosterone, sex hormone binding globulin, dihydroepiandrosterone, and the cortisol. Even the thyroid hormones. These are the important hormones which are to be assessed as per the need of the case. Then what is premature ejaculation? It is the male sexual dysfunction which is characterized by ejaculation which is always or nearly always occurs prior to or within 1 minute of the vaginal penetration. Also, along with that, there is inability to delay the ejaculation on all or nearly all vaginal penetrations. And at the same time, there should be negative personal consequences such as distress, bother, frustration, and or avoidance of sexual intimacy. And prevalence is quite rising, 5 to 10% prevalence is there. And underlying causes may be hormonal dysfunction, there may be diminished libido, there may be exogenous testosterone replacement therapy going on. There may be androgenic suppression of hypothalamic gonadotropin releasing hormone secretion. Sometimes the patient is on higher doses of testosterone, which is more likely to suppress the hypothalamic pituitary testis axis. Alternative therapies for testosterone optimization in men with symptomatic testosterone deficiency who are attempting to conceive include the selective estrogen receptor modulators, some aromatase inhibitors, and human chorionic gonadotropin. These are the things which can affect that ejaculation problem. The main causes can be classified as physical causes, medications, and psychological causes. Then, as far as this evaluation is considered, there is female sexual function index, FSFI. That is the gold standard for diagnosing the sexual dysfunction in women. Most common disorders in females which were diagnosed are the desire and the problem of lubrication. Desire and arousal dysfunction appeared more common in participants with secondary infertility, while lubrication dysfunctions were common in the older participants. Now, what is this FSFI? It is a 19-item self-report questionnaire which use a 5-point Likert scale. What is important is this FSFI focuses the sexual activity of within the last 4 weeks only, and there is a scoring system which ranges from 0 to 36. 0 to 10 means there is severe sexual dysfunction. If the score is between 11 to 16, that means moderate sexual dysfunction is there. And if the score is 17 to 25, that is mild sexual dysfunction. And if the score is about 26, then there is no sexual dysfunction. This is FSFI. This covers the 6 main domains. Which are these domains? Desire, arousal, lubrication, orgasm, satisfaction, and pain. That means the questions which are directed in this questionnaire covers all these 6 domains. There are so many studies done to assess this incidence of these sexual dysfunctions. It is found that the fertile women had a higher score on the FSFI than the infertile women. These are some references regarding this. And most of these studies show that infertile women have some degree of sexual dysfunction with FSFI score less than 26. Also, associated counseling, medical consultations, and consequent fertility tests may result in a feeling of pressure to perform. It adversely affects the sexual functions, deep pelvic muscle contractions, and dyspareunia, also erectile and ejaculatory ability also. Many times what happens is 1 or 2 failures during the sex begins a vicious series of fear of the failure in couple. There may be some arousal difficulties because of distress and anxiety, and that may become a vicious cycle. Sexual activity may become a battleground for control, power, and the quest of child. Let us discuss another entity which is now becoming very common, that is unconsummated marriage. Then what is this unconsummated marriage? It is nothing but the inability of a couple to engage in the successful sexual intercourse at the beginning of their marriage, especially in the initial few nights. And prevalence is quite high nowadays. It ranges from 7 to 63%. In this situation, many times what happens, first sexual intercourse may be delayed for years too, or maybe never happened at all. Some cases are coming like this, 2 years, 5 years of unconsummated marriage. While medical and therapeutic interventions are available nowadays, still many people are suffering in silence and feel embarrassed about their condition. They are not coming forward. That is why actual incidence is difficult to know. Then question arises, why there is problem in the consummation? First thing, a problem with the sexual functioning may be in one or both partners, that is preventing the intercourse. Second thing, they may be ignorant and inhibited about the sexuality. And third thing is, sometimes either of them might have any experience of sexual intercourse with the another mate, but they are unable to perform with our index partner. That is also one of the facts. Then which are the factors contributing to this unconsummated marriage? As far as the females are considered, there may be vaginal penetration phobia, there may be vaginismus, dyspareunia, there may be low female sexual desire. And in males, there may be premature ejaculation, erectile dysfunction, low sexual desire, physical problems like spinal cord injury may be there, hypercholesterolemia may be there, some associated risk factors like diabetes, hypertension, smoking, alcoholism, maybe the positive factors, and other factors like religious, cultural, and psychological factors. There may be lack of sufficient sexual information. There may be misconception about the genitalia. Sexual performance anxiety may be there. Lack of privacy may be there in some cases. In some cases, there may be past history of sexual abuse in adolescent or in adult age. And also, there may be strict religious rules or sexual limitations may be there. These are the causes which can contribute to the unconsummated marriage. Yes, definitely, it may cause the detrimental effects on individual or the individual partners or to the family. And main effect is on the psyche of the individual partners. They get disturbed. There may be depression also. It can lead to low self-esteem in the individuals. And then what happens again? The blame games start between the partners, between the family members, and both the families. And also, in some cases, there may be extramarital affairs too. And of course, both partners can face the frustration, depression, and finally, that may lead to the annulment of marriage and up to the divorce too. Then how to manage this unconsummated marriage? Again, what is important is the thorough assessment for to reach the definitive diagnosis. Thorough assessment of what? Couple's sexual history. Couple sexual history should be in detail. First, individual history can be taken, and combined couple history can be taken, must be taken. Then assessment of physical health of both the partners, complete general examination, and that is reproductive organs or genitalia. And third important is the assessment of psychological factors. As far as the treatment of this condition is concerned, I will just mention the principles of treatment. Sex therapy is very important in these cases. Cognitive behavioral therapy is very useful. Sensate focus is useful. Again, communication and relationship counseling. Communication is a different part because communication is the main key to the solution, and communication between the partners. And relationship counseling is very, very important to build the healthy relationship between the partners. And again, education and skill building is also very important, and some relaxation techniques can be taught to the couples. These are some references about this. Thank you so much for patient listening. Thank you so much.
Thank you, sir, for your elaborate lecture. Here I am seeing this is great initiative. I am seeing I think from Tamil Nadu 7-8 societies, and from Maharashtra also. I would like to congratulate Dr. Madan Kamble and Jay Kumari Kamraj for this great initiative and very nice lecture. Thank you, sir.
Thank you, sir. Thank you.
Any other? Anita madam is here. Madam, anything you want to add up? Namaskar, madam.
It was nice to participate as a chairperson to such a different topic. Actually, my always was area of interest is high risk obstetrics, but this was something different for me. So while counseling the people, infertility couple, I will definitely make it a point to take a proper history, physical examination, investigation, and psychological and social factors are supposed to be considered. Really, which are very important. So, sir emphasized importance of all these factors, which are definitely important tip for us to be in daily practice. Thank you so much, sir.
Yes. Thank you, Anita ma'am. Actually, the objective of our sexual medicine committee is to create and spread the awareness among our members, all Foxians, at least who have the knowledge about this sexual history taking, which is very, very useful in our clinical practice.
Yes, sir.
It is not expected that everyone should be a sexual health expert or sexologist, but the basic thing should be known.
Definitely, sir. Thank you.
Thank you. Thank you.
So we are moving on to the next session. Can I have the welcome, Pratik sir? Welcome.
Hello, madam. Good evening. Thank you for inviting me.
Can I have the chairperson? Yeah. So I have the great pleasure and honor in welcoming and introducing Dr. Pratik Tambe. Sir is the IVF consultant and the gynec endoscopic surgeon from Ashirwad IVF Mumbai. And he's an international, he has got the international diploma in advanced laparoscopic surgery. And he's the governing council member of Indian College of Obgyn 2021 and 2025. And he's the governing council member of the Indian College of Reproductive Medicine 24-26. And he's the patron and the managing council member of the Mumbai Obgyn Society 2013 onwards. And he's the recipient of so many awards, 36 awards from MOGS, ISAR, FOXY, AMOGS, prizes and awards. And he has edited 32 books, 4 of FOXY focuses and handbooks, 9 from 9 GCPRs and 11 key practice points. And he has contributed more than 100 chapters, invited faculties more than 1,000 events, and organized more than 800 CMEs. And he is the convener of the ICOG Reproductive Medicine course 21-25. And he is the peer reviewer of the Journal of OBGYN of India, Jogi 2012 onwards. He has got a lot of awards and a lot of accolades. And it's a really a great honor to have you, sir. And the sir is the candidate for the ICOG Secretary 26-27. And we wish you, sir, for all your success in your upcoming elections. And over to you, sir, to introduce your panelists for this.
Thank you very much, Dr. Jairani ma'am, for inviting me. My gratitude to TNFOG as well as AMOGS for organizing this wonderful joint venture program. And quickly, we just have half an hour to conduct this panel since we are already delayed. I'd like to proceed with the introduction of the panelists. We have with us Dr. Kalpana Balamurgan. She is currently the FOXY chairperson for the Infertility Committee. Also served as the vice president of Madurai OBGYN Society. She has many different credentials to her credit. Thank you, ma'am, for joining us. Dr. Kundavi Shankar is a senior consultant and she has multiple accreditations, including vice president-elect of TAPISAR. And she's also been part of the Fertility Preservation Committee. Thank you very much, ma'am, for joining us. Next slide, please. We have with us Dr. Silambu Chelvi. She is from the Coimbatore Medical College, president of the Coimbatore chapter of TAPISAR, executive committee member of TAPISAR, past vice president of Kovai Society, and multiple publications and presentations to her. Thank you very much, ma'am, for joining us. Next slide. Dr. Pungothai Selvaraj, I hope I'm pronouncing the names correctly. If I am not, please do excuse me. I'm not familiar with the pronunciations, so please apologies in advance. She's the managing director of Divya Hospital in Tirupur, practicing OBGYN and infertility since more than 25 years, founder president of the Tirupur Society. Thank you, ma'am, for joining us. Next slide, please. Dr. Vani Pujari is the director of Akshaya Fertility Center and Women's Care, president of the Salem chapter of TAPISAR, joint treasurer of TAPISAR. Thank you again, ma'am, for being with us. Next slide, please. Dr. Nirmala Vijayakumar is a consultant in reproductive medicine from Tirunelveli, and she has multiple leadership roles, vice president of FOXY Tirunelveli, the executive member of IMA from the same city, and president of the TTK chapter of TAPISAR. Thank you, ma'am, for being with us. Next slide, please. Dr. Kanimozi is the lead consultant at ART Fertility Clinics in Chennai. She is the first candidate in India to have successfully finished MCH Reproductive Medicine and Surgery from Ramchandra University. Multiple awards and presentations to her credit, and she's also an executive committee member of TAPISAR. Thank you, ma'am, for being here. Next slide. Dr. Madhumita Arun Karthik is the treasurer of the Salem chapter of TAPISAR. She is also a member of the ISAR Youth Brigade, peer reviewer of Jogi, also publication in charge for Public Awareness Committee of FOXY, and has done several publications for that committee as well. Thank you, ma'am, for being with us. Next slide, please. Next slide. Dr. Dhavashri is a consultant at the SKS Hospital and Clinical Director at Vriksham by SKS Fertility Unit. She's a member of the Royal College, Fellow of the European Board of OBGYN, and she leads the High Risk Obstetrics Unit at SKS Hospital. Thank you, ma'am, for being with us. Next slide, please. Dr. Sridevati Sadashivam is a fertility consultant at Genesis IVF in Road. She's worked in the UK previously, and she's an MRC only pass out in the 2016 batch. EC member of IFS PN chapter. Thank you, ma'am, for being with us. Next slide, please. Dr. Revati Rani is the president of Appluj OBGYN Society. She's the director of a private multi-specialty Apex Hospital since over 11 years. She has multiple different presentations and awards to her credit. She's a well-known fertility consultant in Maharashtra. Next slide, please. The slide is blank, but I am going to measure that he's an infertility consultant, seeing that he is here in an infertility panel. Thank you very much, sir, for joining us. Next slide, please. Dr. Shalaka Mamedwar is a consultant at the Manome Testing Baby Center in Chandrapur, and she has the first IVF center of Chandrapur district way back 14 years ago. He is the vice president of IMA and ex-vice president of the Chandrapur OBGYN Society. Thank you, ma'am, for joining us. Next slide, please. I think we have one more, Dr. Prajakta Gurude. And next slide, Dr. Ashwini Shinde, I think, is not joining us. So if I can share my screen and we can get this panel started. I will need somebody else to stop screen share so that I can screen share. Yeah, good. So this is going to be a brief, quick, and basic panel on maximizing ART success. And as always, when I do a panel, there are a few things that I like to keep in mind. Let's keep it basic, simple, and practical. And hopefully I will be able to speak a little bit in between because there are 14 panelists. Directing the flow of conversation is going to be a little difficult. Welcome everybody to our panel. Let's keep it basic, simple, evidence-based. And if we have time at the end, then maybe we can do a rapid fire. So this is the case that we're going to discuss. This is a 32-year-old lady. Her BMI is 34. She's trying to conceive since 7 years. Male factor is fine. All that has been ruled out. So we're going to focus primarily on the female partner. She's undergone several cycles of ovulation induction, multiple cycles of IUI with gonadotropins. She has PCOS. Her BMI is 34. She's obviously an obese classic PCO. She wants to undergo IVF. So let us plan her treatment cycle and we will go in the order that is printed on the invitation. We'll start with Dr. Kundavi. She's obviously the senior most of all the participants. So, ma'am, what are the key points that you would like to take into account before you plan the treatment cycle for this country?
This is a lady with a BMI of 34 and she's been married for 7 years. So the longer duration of infertility, age is okay, 32. The BMI is 34. We don't have, just said it's had several cycles of ovulation induction with 3 cycles. We do not know whether she's responded with an ovulation induction or with for the IUI. I think the main
probably she has ovulated, but we don't have her hormonal test, which is the glaring omission in this slide. So probably that's the first thing that you would like to do, given your vast experience. You would like to look at the hormonal test results and then tailor make the treatment protocol for her.
Exactly. I would just look at her, the antral follicle count, the AMH, the AFC, and an AMH.
Very good. Thank you. So I think that's the very basic way to approach everything. Let me go to Dr. Silambu Selvi. Now, this patient has undergone several cycles of ovulation induction and she's undergone IUI as well. But we don't have any information, ma'am, as to whether a hysteroscopy or a laparoscopy was ever attempted in this couple. With 7 years of infertility, do you think that's something which is important and may have an impact on the outcome? You'll need to unmute yourself. You're muted. Ma'am, you'll need to unmute, please. We can't hear you.
She's obese, married for 7 years, cycles of ovulation induction tried, and IUI done, but I do not know whether the tubes were evaluated.
Exactly. And these days, there is a fashion amongst the younger ART crowd, those who directly go into ART after passing out their DG or MS, that they want to purely practice infertility, so they never touch a telescope. They don't even know what a hysteroscope sheath looks like.
So, I want to know the AMH and LH status
Yes,
of the patient.
very good. So that
And
is one of the things that you would like to do. Very good.
in that case, if the AMH is also very high, we can give a try after. But if she is already ovulatory, the ovarian drilling, I don't think that will be much
Yeah, at
useful.
the age of 32, any which ways with a long-standing infertility, we would like to try and avoid ovarian drilling, especially if she is already ovulating with response to gonadotropins. So ensuring that the uterine contour is normal, that the interior, the cavity is fine, that the tubes are patent, though the tubes don't really have any bearing or impact on fertility as a result of ART or IVF, but at least ensuring that there is no tubal pathology, there is no, how can I put it, salpingitis, that sort of basic stuff needs to be evaluated before we put her up for an IVF cycle, considering that she is a
Along
long-standing.
with that, she is very obese. Lifestyle modification. Of course, certainly she will not lose weight. Parallelly, it has to. So, and
So BMI of 34, I think, is pretty much acceptable these days. Everybody has a BMI of 30 or 35, especially if you're an obese classic PCO. Unless you have crossed 35, I don't think we pay too much attention to it. But you're absolutely correct that even a 5% reduction in the weight will make a huge impact as far as the number of follicles that she generates, the oocyte quality that you get, ensuring that you have better quality metaphase to oocytes. All of those will definitely have an impact. Yes, you're
and
absolutely
whether
right.
she is on metformin.
Yes, that's a very good key practice point that we need to start her on metformin if she's not already on it, because that information is missing here. Can I go to Dr. Vani and can I have some more tips and tricks from Dr. Vani as to what else she would like to do in this patient before we plan for an IVF cycle in her? You're muted, ma'am. Please unmute.
Yeah. So it says several cycles of ovulation induction and several cycles of IUI done, but
Correct.
it is worth our time to go through actually what happened in all the cycles. It may take us.
In an ideal world, we would like to have the cycle charts. We would like to have documentation on what was the
Whether
protocol that was
whether
used, what was the dosage used.
what drugs were used and oral ovulations
Absolutely
are one
correct.
of the
Perfect.
trophies, and how she responded to all this, and whether
Very
she
good.
responded or not, and how many follicles with all this, and then
Correct.
how was her endometrium, and when was the IUI done actually, and
Perfect.
whether the cycle, what was
Whether they did a
the
color Doppler, they looked at perifollicular vascularity,
yes,
whether they looked at
everything
TSV.
matters, and whether uterine support was it given or was it given properly or not.
Excellent, excellent. Very good
So
key practice points.
all that looking into past history will give us whether she was tried enough number of cycles in a proper way. So if that
Yes.
has happened, then we have to look at IVF. So when we are looking at IVF, probably because she has a 7 years of infertility, she has done enough of doing this ovulation, inductions and all those things, and her male factor is normal.
Very good.
And so in IVF, we have whether we should look at her fat first or fertility first. You're saying 34 is acceptable, but please, if possible, now that we have this GLP-1, we can try a little bit of fat reduction if possible. In PCO patients, fat reduction might help. Non-PCO
I
patients,
would love to talk about GLP-1 today, but unfortunately, we don't have time. But we will talk about
I'm
it
just
someday. I
just
will come back.
mentioning it. So just fat first or fertility first. But she's 32, and if there is some time you can allot, then we can do it. But otherwise, we can, based on this past history, we can formulate how to go about stimulating her in IVF cycles.
Very good. So in an ideal world, we would like to have the cycle charts from the previous stimulations, look at how was the follicular development, whether she had multifollicular development when the oocyte trigger was given, whether she had good subendometrial blood flow, she had good endometrial thickness, whether she had good perifollicular vascularity, whether that ovulation and the IUI were properly timed to give the best possible results. At that moment in time, obviously the husband's count motility was probably appropriate. They went ahead and did the IUI. But then, as you rightly pointed out, what was the luteal phase support given? There are many couples who don't take any luteal phase support. I mean, there is one school of thought that says that in IUI, don't need luteal phase support. Everything is fine. Mother Nature takes care of everything. But that is very far removed from the truth. You and I know that the moment you administer gonadotropins in any cycle, even if it's a timed intercourse cycle or an IUI cycle, luteal needs inhibited, needs to be has to be done justifiably. So thank you for those beautiful key practice points. Somebody mentioned antral follicle count, and can I ask Dr. Pungothai ma'am, what exactly is this antral follicle count? How does it make a difference in our IVF cycle?
To assess OHSS, if the antral follicular count is more, we can anticipate OHSS in that particular patient when we.
So how do you look at this antral follicle count? How do you measure it, and when do you measure it? For the sake of the audience, can you explain that to us?
In the early follicular phase, we measure.
Yes.
If
so you do that as a baseline scan on day 1 to 3 when the period is going on?
Day 2 or day 3, we can do.
Yeah, it's very messy and distasteful. Many patients refuse, they don't like it. It's quite ugly to do it and to even request the patient. But then we have to be able to convince the patient and counsel her that this is the best time to assess the antral follicle, rule out ovarian cysts, and then we can tailor make the gonadotropin protocol specifically for her case. We have to individualize the treatment. There is no free size as there is for clothes. There is no one size fits all in ART treatment. Therefore, we have to individualize the treatment. And that counseling is very important, especially from a senior clinician. So you said that you look at the number of antral follicles in both the ovaries, ideally on day 1 to 3, while the menses are going on. And what is your cutoff for what is normal responder and what is your cutoff for hyper respondent?
If it is more than 20, it is a hyper responder.
Okay. So that is the sum of both sides, both right as well as left. Am I correct?
No, on each side.
On each side, 20?
Yeah.
Okay, so that's a huge number of follicles. And do you have a modern machine with an 8 megahertz probe? Only then you will be able to see those 20 follicles. If you have an older machine which has maybe 3.5 or a 5 megahertz probe, obviously you won't see so many follicles. You will miss many of them. So that's a very important key practice point, that you need to have one of the modern machines with a high resolution probe. And that is when you will get the correct number of antral follicles. Dr. Kundavi, would you agree with this point of view?
Yes, sir. I think sometimes we have seen, though they look like a PCOS, the high BMI, we have seen the AMH being on the lower side. I think we should be very, very careful to even to repeat the AMH.
I'm so happy you brought up this point, because AMH and AFC don't always go hand in hand. They don't always correlate. Dr. Madhumita, have you seen that happen in your clinical practice as well?
Yes, sir. Very often, like we look at the scan, we think okay, it looks like a PCO. Like we expect the AMH to be somewhere around 4 or even higher, but many times it just comes out to be like 2 and all that. So like sometimes, and initially I used to like ask the lab to recheck and all that. Then got to know, okay, this happens. Yes.
Correct. And ideally, you should be looking at an AMH value which is done in a reference lab or an NABL accredited lab, and ideally the sample has to be processed immediately. It should not be collected in one place, transported to a place 40 kilometers away, and then processed in the central lab somewhere else. That will give you erroneous values, and that will mislead you. You will not be able to correlate the AMH and the antral follicle count.
Again, there is another school of thought. If you do the AMH in the second half of the cycle, then it is on the lower side. So probably I think we should be doing it along on the second day of the periods.
Yes.
Again, if she's on OCPs also.
Yes, if she's been suppressed for a prolonged period of time with oral contraceptive pills, all of these little things matter when it comes to assessing your AMH values and correlating it with the antral follicle count. So, Dr. Madhumita, since we are with you, what is your cutoff for normal responder and hyper responder vis-a-vis the AMH value?
So AMH, generally, if it is more than 3, I see the patients like usually like they have a higher response.
So 1 to 3 would be normal, more than 3 would be hyper response. And there
Yes.
are some patients who have values of 10, 11, and 12. Are those completely wrong? I mean, that lab is not actually processing the sample properly, or you can genuinely have an EMH value of 10, 11, and 12.
So
Yes, sir, we can
Sometimes
still
I wonder whether they've confused the LH and the AMH and actually substitute the LH value for the AMH. They've typed it wrong. It's a typing error.
it's like an hyperandrogenic PCOS. So these group of people may not even respond. We might think
Exactly.
they're hyperstimulate, they may not respond well.
Very good. So if you get values which are more than 6, this points to a distinct group of patients. They may either function as exquisite hyperresponders or they may be extremely poor responders. Both the extremes are good.
resistant
And
side.
yeah, and if you get those kind of values, then you need to be very careful. You need to monitor the patient carefully. And we are coming to that part of the discussion just now. So let's go to the types of protocols that are available to us. We've counseled our patient that she needs ART, and for ART, we need to stimulate her. Stimulating her means we have to use gonadotropins. Now, Dr. Indranil Yadav, sir, if you are going to use gonadotropins to stimulate a woman who is a non-obese classic PCO for an IVF cycle, what are the key practice points that you would like to bear in mind, and how would you counsel this couple?
Yeah, first we will see for AMH and second
Okay.
we'll see for BMI. So in
Yes.
PCOS, it is expected that we start with low dose.
Right.
Probably the basic dose may be 187.5 or 225. But suppose
Okay.
if the BMI is crossing more than 30, maybe we can add 75 units more. The preferred injectable may be recombinant FSH, which we can start with because it is
Okay.
already a high LH condition. And second
Okay.
thing that we have to always see if the FSH levels are rising above 10 or not, so that you may know that like what may be the response for the patient priorly. Also, maybe we can simultaneously go for like previous cycle priming with metformin or androtat gel, which may sensitize for the hormones. So
Okay.
maybe this is the best protocol what we can use for PCO, so that we are in capacity to actually titrate the controlled ovarian stimulation in a better way.
If I can quickly summarize what sir has just said, that we would like to start with the smallest possible dosage. We err on the side of caution. We take the AMH and antral follicle count together into consideration. Start with a small dose of say 150 or 187.5. If you're using recombinant FSH, those are easy because that uses a pen and you can just dial in the dosage on the spiral, at the end of the pen. Whereas if you're using injectable gonadotropins, if you're using FSH or HMG, ideally there is not much difference in the ovarian response, whether you use HMG or FSH as per the Cochrane meta-analysis. But then you will not be able to fine-tune the dosage. Entering in something like 125 is not so easy. Entering 187.5, 137.5 is not so easy. You can start maybe 100, you can start 75, you can start 125, you can start 150. Those are pretty much okay and those are easy to do. But exactly what dosage you will start in which patient, that is something which you will only be able to assess after you've taken multiple cycles of stimulation and you develop that sixth sense. Of course, there's also a sliding scale which is used to identify what is the correct starting dosage. Let me ask Dr. Revati Rani, what is her preferred starting dose in patients who have PCO and she's going to stimulate for IVF?
Yeah, so as you sirs correctly just said that there are different nomograms which are available for starting the dose. So in which we have already discussed regarding the weight of the patient, age, AMH and AFC. Additionally, we can always go for stromal blood flow and assess and see whether if she is, hyper responder. And depending upon if the PSV is more, then in such cases it is better to start with the lesser dose. And
Okay.
as we just discussed that as per megaset trial, we can as well use HMGs for those patient, and which gives the equal response. And with that dose, we all prefer antagonist protocols for PCOS because she is a PCOS, and we have already discussed the doses. So we have
Okay.
to consider everything before we start the dose, and accordingly we can do the step up protocol.
Okay. So, Dr. Vani, I'm going to come back to here. I'm going to ask you a leading question. Is antagonist always the best choice for PCO women as far as ART stimulation happens?
I would say PPOS is giving a good
Okay.
thing for, because especially in obese and PCO women, there are a few studies which I happen to come across. Because in obese PCO, we are worried about the oocyte quality for whatever reason, why oocyte gets damaged or becomes bad during the stimulation, or was it bad before that, we don't know. But the studies which are conducted means antagonist again to PCOS, even randomized studies, a couple of studies have shown that the oocyte quality is better with the PPAS protocol. So I would say, anyway, we are not going to go for long agonist stimulation. So we only
long is completely out.
Yeah, so we have only antagonist and PPAS. I would say both are almost equally good, and if my personal preference will be PPAS.
So if I can ask you about PPOS, when do you start your progesterone? Do you start right from the beginning, from the first, second day, or do you start it on day 6, 7 like the antagonist protocol?
It is my personal preference to start on day 2 because I think it gives us the benefit of the long agonist protocol. It keeps everything silent and quiet, and so we can use our gonadotropins and our
And it gives you synchronized follicular growth. Have you seen that? Just like the agonist protocol?
Synchronization. Yeah, that is what I'm saying. It gives the benefit of agonist protocol and not being an agonist, and we can use agonist trigger. So I think it has a double benefit there.
Very good. So do you use medroxyprogesterone or do you use dydrogesterone?
I use both. But in all labile patients, I think that dydrogesterone may not work that much. So there can be some LH.
There can be some escape.
Yeah, there can be escape.
And
So
if there is an escape, then you had it.
yeah,
that entire
but
cycle is
if I suspect that in PPOS, I don't mind using medroxyprogesterone because I don't mind medroxyprogesterone suppressing everything, and then I have enough number of follicles to play with. But in other cases, I'm more likely to use dydrogesterone. I don't want a complete suppression, too much of suppression.
So let's get the car back on track. I'm going to ask Dr. Kundavi ma'am. Do you have any experience with these step up and step down protocols? Do you think they are described in our textbooks, of course, but do you think they are safer in patients with PCOS where you don't want them to suddenly explode?
So when we talk about the low dose step up protocol, I think one, we have to counsel the patient that they should be patient enough to come for the regular injections for a longer duration.
Doctors also have to be patient enough.
And even the doctor has to be patient enough. So I think telling them, start with 37.5, then you slowly increase. And then sometimes what I do, I go with the step up protocol, then reduce the doses rather than going with a low dose step up. So I go with the higher dosage. And then once I see a follicle recruitment of 13, 14, and I stop the gonadotropins and I see the follicles growing on their own. So I would do with that.
Okay. So you are a believer in the step down protocol, not so much the step up, because that causes monofollicular development and it defeats the purpose of doing an IVF cycle, because in an IVF cycle, you need more
molecules. And moreover, regarding the PPOS, I think I would prefer more of a flexible when I see the follicles around 14, because
similar to the antagonist protocol.
Similar to the flexible ones.
Okay. So now let's go back to Dr. Revati. I think she was trying to say something and I interrupted her. Apologies. Please go ahead.
No, sir, I just wanted to mention this only. If there is synchrony when we start the stimulation, then it is good to go for follicular PPOS. Otherwise, it is better to go for flexible PPOS because otherwise we don't get the, cohort is not that good. So the patient might be suppressed. So we have to individualize. Yes.
So I'm going to ask a very important question now, which has troubled me for a very long time. I see 20 follicles on ultrasound. When I actually do the oocyte retrieval, I get about 15 of them, and only about 7 or 8 of them are metaphase 2 oocytes. Is this everybody's experience or is it only my experience? Am I the one who's doing something wrong and I find that only 7 or 8 are metaphase 2 out of 20 that I see on ultrasound?
It's very common, sir.
Very common.
So where are we going wrong? Is there something wrong with our stimulation? Is there something wrong with our protocols? Are we not giving enough antioxidants? Where exactly are we erring? Why are we not getting at least 70 to 80% metaphase 2 oocytes like we get in other patients?
So number one, because you normally tend to have this asynchrony of the follicles. Number two, the trigger, sometimes we give them the agonist, but I think there are a lot of papers which have come out now. You can still give a same double trigger with the agonist. You give it around 35 hours and next day you
Playing with
give.
fire, but yes, okay, I'll grant you that.
So final maturation would be better.
Okay, okay.
Also,
I
there is
So
a
this is a common
significant,
and universal problem which all of us have been finding. Yes, Dr. Indranita, go ahead.
Yeah, actually, previously when I was in my learning phase some 12, 13 years back for IVF,
Yes, sir.
I
Yeah.
used to see that 18 to 20 millimeter follicles will only yield metaphase two sites.
Correct.
But as soon as I'm getting older in IVF field, I'm seeing that 22, 24 are also yielding oocytes. So maybe one day delaying in the trigger actually is making more number of mature oocytes is the first thing which I can say. Second thing, that practicing IVM, in vitro maturation, does help in increasing the maturation oocyte. Third thing, we are very, 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 very much scared about OHSS, OHS free clinic, but maybe
Absolutely correct.
a partial recombinant HCG trigger with 125 microgram or 150 microgram does help with co-triggering or maybe 1500 of HCG units. Just the need to do is that post pickup start her with elagolix, which is the best possible oral antagonist which we can have, which we can continue for 5 days. And I will bet you that it is a OHSS free clinic if you give elagolix. So maybe these are the changes which may increase the maturation or
Thank you for sharing those valuable insights with us. We'll come to HSS 3 clinic in just a couple of minutes. Before we do that, I wanted to ask Dr. Chilambu Chanvi. Yes, ma'am, Dr. Kundari, go ahead.
Few articles which say when you check the LH on the day of the trigger, when the LH probably is on the lower side, the agonist plus with a slight risk of an OHSS, you can add a small dose of HCG like 1000 or 1500. So again, we'll have to look into
That may help your final maturation and increase the number of metaphase too.
Yeah, I'm actually in a study now in which I'm actually studying PCOS patients, in which actually we are in capacity to give a monotonous triggering like 0.2 deca or that triptyline or 2 ml of lupride. But here if you see that if we can, the maximum dose of triggering for triptyline acetate may rise to 0.4 and also for lupride it may rise to 4 ml. So now I'm trying that with 0.3 triptyline acetate or 3 ml of lupride, maybe the issue of PCOS having empty follicles is actually getting resolved. So these two things, dealing one day trigger with 0.3 or 3 ml of lupride with half dose of HCG is actually resolving many of the issues, which I in my practical practice am practicing now.
And if we are giving only agonist trigger, and when exactly we are giving agonist trigger also matters. Sometimes it may take longer time for the follicles to go through those meiosis and then produce that M2. So we may have
It depends on which wave of folliculogenesis is actually being harnessed at that point.
Majority of whenever we are giving HCG trigger, sometimes we aspirate at 35 hours. That is, but for this maybe we'll have to aspirate at 37 or 38 hours. So we get more M2 if we give more time. I have found in my practice.
We have Dr. Kanimozi with us. I think she's been unable to rename herself. So I'm going to ask her, we're going to go back to the basics. We've started stimulating this woman, say with 150 IU of FSH. It's not recombinant. It's highly purified urinary gonadotropin that we're using. How many days do you give your injections and then call the patient back for reassessment or review? What do you do in a clinical practice?
Ideally, start from day 2 of cycle. I usually call the patient on day 5 or day 6 for the checkup.
Okay.
Basically, if it's an antagonist
And
protocol.
how do you assess the patient? Do you only do a transvaginal scan, or you also do blood hormonal investigation?
No, sir, I don't do hormones. I don't do checks.
You don't believe in hormones at all?
No,
No
sir,
echo, no
sorry, sir,
LH,
I don't much
pure
believe in that.
ultrasound.
Yes, sir.
Thank you. Somebody who matches me. I'm very happy that somebody says that I rely only on ultrasound. I personally monitor the patient and ultrasound is enough.
I don't do any hormones during the stimulation, sir.
Expensive investigation.
Yes, I don't do any hormones during the stimulation, sir.
Okay. So you call the patient back on day 5 or day 6. You've assessed her. What specifically are you looking for on the ultrasound? For the
So
benefit
basically,
of
I
the
just
audience?
look for the number of follicles, anything which is more than 14 millimeters, to check whether to start an anta or not.
But on
Most
day 5,
probably,
6, you are unlikely to get something like 14 millimeters.
Yes, sir. But most probably I'll call on day 6 because if the patient has more number of follicles, because they produce endogenous LH will be going high.
Very
So
good.
preferably I try to start an ANTA on day 6. I don't
Okay.
go
And how
on.
many follicles do you actually expect to see? What is safe and what is unsafe? That is what I'm asking you.
So if I see more than almost 10 on either side, I'll be a little scared because on either
You
side,
are
10,
going
10
to be a
each.
little scared.
Yes, sir. Yes, sir.
And what will make you very scared?
Yes, sir. Definitely.
10, 10 on each side will make you a little scared, but what will make you very scared? What number will make you very scared?
More than 15 each?
More than 15 each. Yes, that is the time when I should ideally cancel the cycle there.
Or reduce the dose of gonadotropins.
Okay. But does
And
step
she's
down
definitely
actually
going
help?
to respond poorly. Future.
So that brings us to a very important point. There are these protocols called as step down protocols. You start with a high dose, get more recruitment, and then you step down the dose as early as possible. So what you're describing actually is a step down. Does that step down actually help?
No, sir, doesn't help much. But the number of the E2 levels will come down a little bit.
Okay. Is it also possible that the follicles will be starved of gonadotropin and the quality of the oocytes will not be very good?
Yes, but there are studies stating that, but I don't think so, sir, because what personally in my experience, I have not reduced the dose. I go ahead because sometimes there'll be multiple follicles, but none of them will be more than 10 millimeters.
So
In
then
that
would you agree with me that the starting dose is the most important because it
yes, sir,
either
very, very
makes or
important. Very
breaks your
important.
cycle, it
Yes, sir.
ensures your safety, it
Yes, sir.
prevents OHSS, and it ensures that you can get comfortable sleep for the next 10 nights and you're not staying awake thinking, okay, this woman is going to throw 40 follicles, this woman
Correct.
is going to give me trouble.
Correct. Yes, sir.
Correct. So the starting dose is very important, and that is why the senior clinicians are always a little more on the cautious side. They like to err on the side of caution. They will start maybe 25 IU less, 50 IU less. Maybe they'll get 3 or 4 follicles less. And that ensures that the patient does not go into ovarian hyperstimulation. Dr. Revati, can you tell us what else can we do to prevent OHSS? We've talked about metformin. We've talked about lowering the starting dose. We talked about starting the GnRH antagonist earlier. What else can we do? Is there anything else that we can add to this?
At the time of trigger, we can add cabergoline to the patient.
Yes. Okay.
That would reduce it. And
Okay.
obviously, when the E2 is more than 3,500 and we are having more than 15 follicles, we should not, feel tempted to give HCG for good quality of. So, like having the safe practice, I guess, is
So
very
dual
important.
trigger is to be avoided at all costs in these patients.
Preferably with these cutoffs, yes. So that would
Dr.
ensure that.
Silambu, tell me, do you think that coasting for 24 hours or 48 hours is a good way to ensure that the patient doesn't explode and go into bad, unmanageable OHSS?
No, sir. Posting I don't prefer.
You don't like coasting?
Yes, sir. Yes, sir.
Okay.
In my
Anybody else who likes coasting, especially in those dangerous patients where you're scared E2 is going to cross 4,000?
Staging outdated now.
It again compromises the quality of oocyte.
Quality of dosage. So I will
No, it
continue
does.
with the dose.
So when we have the antagon and agonist trigger, I think the then the
OHS is not
freeze all policies, I think the risk of we have hyperstimulation things, but I think those days which we have to have the OHSs, I think it's really come down now.
Very good. Thank you. So I'm going to ask Dr. Indranil, sir, before you start your stimulation, do you always advise your patient who is a known obese classic PCO that in your case, we are going to freeze all your embryos? Do you always say that? Freeze all always in PCO?
Strategy is like permanent, maybe in PCOS and non-PCOS patients because we have actually good results with FET rather than phase cycle transfer. So we are actually following freeze-all strategy in case of any patients which
So
we
all
are.
PCO always freeze all.
Yeah.
There is no case of PCO where you would consider doing a fresh transfer.
No, she will land up into OHSS, which may be late OHSS, and that may complicate the case. And lastly, sometimes to control that, we may have to abort also. So no need.
I know. Late OHS is a nightmare. It's very difficult to control, especially if it is OHSS related to pregnancy, because when your beta HCG is in thousands and lakhs,
Cause
and
late
that is a complete
uncontrollable actually.
Correct.
Late OHSS.
So since we are talking about freeze all and stage transfer or segmentation strategy, which Professor Paul Desbois brought out 15 years back, I'm going to ask Dr. Kanimoji now. You've done the freeze-all. You've prevented OHSS from happening in this patient. You've given her 15 days of a break. She comes back in the next cycle. When are you going to do your embryo transfer?
So the next cycle I prefer giving because there'll be multiple corporal lutea because then
Yes,
if you give a go ahead with an agonist trigger, she'll get her periods within a week's time. Usually
Correct.
that is what we routinely see. So I
Absolutely
give her a
correct.
break-free cycle. I'll break her for next cycle and then I'm going to call for the very next cycle.
During that break cycle, what do you give her? That is all important.
But sometimes I go ahead with OC pills. Sometimes if the patient has any irregular periods or something like that, I have a withdrawal bleeding with medroxyprogesterone from day 21 to day 25, and then I can call
Okay.
her on day 2.
Okay. So you give her a pill-free month, except for the last 5 days when you're giving her MPA, so that she
Yes,
gets
if she has irregular periods. If she has regular periods, I'll call her on day 2 and start.
Okay, so you'll give her a 1 month pill-free interval, no medications, none of the masala that we give all our IVF patients, and you just give her a complete break. Dr. Vani, would you agree, or would you like to give something in that break month?
Not just a folic acid or whatever vitamin she was on. I don't.
Okay.
I personally also I don't give anything. If I'm planning any hysteroscope or something like that, I'll use that month to do all that thing.
Okay. But do you find that the ovaries, when you've retrieved 20 follicles on both sides, they are not going to come back and shrink to a normal size within one period?
We can always check the next period because if we have like a PCO who has 20 on each side, mostly 10 or 15, mostly in 1 month or so, it will come back. So we are going to do a baseline scan on day 2 before we start to get her endometrium ready. If we see that there are still multiple corporal lutea present in the ovary, we will extend the free period.
So then that means 2 months of break.
It is depending on what we see on the day 2. We can we can tell the patient beforehand that most of these people as soon as the eggs are out and embryos are made, they want them to be transferred immediately.
Exactly. Somebody may not like waiting for 2 cycles. That's what I'm trying to say. Dr. Pungota has raised a hand. Yes, ma'am.
Sir, I would also ask them to avoid intercourse also. Sometimes some follicles would not have aspirated. And I had experience like that. A patient conceived in between.
Spontaneously. Despite your best efforts.
It was an ectopic pregnancy.
Oh my
So
God.
we managed
That's
it
even
medically.
worse. Dr. Indrani Yadav raised his hand. Yes, sir.
Yeah, actually, for giving a UCI cycle than 3 months so that it suppresses the ovary. So there is another study in which we can actually give her as soon as we are finishing with the pickup, we can give progesterone primed with a leupride depot, which may be actually suppressing her. So
yes, so leuprolide depot is something which I used to use, but there isn't much literature about it. So we never talk about it much outside the confines of a private conversation. Also now, as you mentioned earlier, Elagolix is available. So Elagolix can also be given, and it's the oral antagonist. The patient doesn't need to keep coming back to the clinic to continue the GnRH antagonist injections. Often I find that these couples are extremely stressed. And when they come back to you in the next cycle, they immediately want to undergo an embryo transfer. So at that moment of time, I do the scan, I show them that the ovaries are large, that they are bulky, there are corporal lutea. And sometimes the scan itself is also painful for them, even 15 days later or 10 days later when they get their period. So they're happy to have 1 month of break. And during that month, sometimes I put them on a second generation COC, which helps the ovaries to shrink. Then subsequently in the second cycle, the second month after doing the oocyte retrieval, we plan the FET cycle. How we plan, what exactly are the specifics of FET, that's a different discussion altogether. I'm afraid we've run out of time. So before we end today's wonderful panel discussion, I would like each of our panelists to give one simple take-home message to our audience, and then we'll close this panel. We'll start with Dr. Kundavi, ma'am. Anything you would like to convey which we've not discussed so far, ma'am?
I think I agree with the panel, excellent panel. So patients, it has to be an individualized starting dose. Look at the past history, whether she has responded for the particular dose which you're planning to start. And you tell the patient that she has to reduce weight because the BMI is 34. and then she would require a slightly a higher dose, probably a longer duration of gonadotropins when compared to another colleague who's only about BMI of 24 or 25. And though we expect probably 20 follicles are there, we may get only about 5 or 6 eggs. That also to be informed to her, and probably the trigger to be individualized. But I would go with double trigger with the agonist only, not with an HCG. Freeze all policy, and then you go ahead. But one thing I would tell them that if the ovaries are big, enlarged, you have to tell them if there is a severe pain, there is a risk of even a torsion has to be informed to the patient to report to us anytime.
Correct. So all those important counselings and ensuring that you give a printed discharge summary, report immediately to the hospital in case there is 1, 2, 3, 4, 5. All that has to be impressed upon the
And these patients are also prone for a thromboembolism when they are pregnant. So I think that needs to be kept behind our mind.
Sure. Thank you very much. Dr. Vani, any key practice points you would like to cover we have not discussed so far?
Most of the time we miss to arrive at a proper diagnosis before starting any fertility treatment. We should have the diagnosis for their infertility, based on, I mean, starting from the age and whatever has happened in their lives so far, and their weights, and then how their ovaries look, and everything. So if we can spend enough time on that, it will really save our time when we are treating them, because we can arrive at proper diagnosis, and then we can probably treat much better even before she goes into IVF and during IVF also. So I think that is one key we should not forget. Most
The
of the
art
time,
of medicine lies in the individualization of the
as
therapy.
soon as we
Applying
see,
those concepts.
as soon as we see a fertility patient, immediately clomiphene or letrozole is given even before they're investigated. No, we should spend enough time to investigate and then start.
That's why I asked that question, whether we should do hysteroscopy, laparoscopy, because sometimes it's not mentioned, it's not even offered to the couple. They don't even know about it. Thank you. Dr. Revati, anything you would like to add, please?
Yes, sir. Regarding this patient particularly, we were discussing, then we tend to ignore the metabolic panel of the patient, like getting her lipids done, getting her glucose challenge test done, and seeing for hypertension. So proper good physician consultation is also very important for her obstetric outcome.
Fitness for pregnancy, like I like to call it.
So that is very important before we transfer. And sometimes with too much hyperstimulation, we get the quality of oocyte is not good. So we might think of giving mild stimulation to some patients where we haven't got good quality oocytes in previous stimulation.
So that can also be an option. Dr. Silambu ma'am?
So the starting dose is very, very important. Coasting, there is no place. And with agonist trigger and freeze-all strategy, we are reduce the incidence of OHS. And one more point, as somebody told, we can prolong the stimulation even though the E2 is high. Like when reaching 20 size, the size of the follicle, we can achieve more M2s. See, this point we have to view.
So as far as possible, only one stimulation in a PCO woman, get as many oocytes as possible, and aim never to stimulate her again.
Because
you
most
don't
of
want
the
to get
time,
to
the
that
M2s are
90.
very less in PCO patients.
Thank you. Thank you, ma'am. Dr. Indrani Jadhav, sir?
Yeah, here I want to state the importance of adopt if and full development takes 90 days. Maybe if at all buying months time can only give at otherwise no give effort. Kept in mind between
Thank you, sir. There was some audio issue there. We couldn't hear you very well. Dr. Kani, last final words, closing remarks.
Basically, counseling is important at each point of the stimulation, right from starting dose, right from stimulation, and during stimulation, post complications, everything has to be explained to the patient. And one thing in PCO, though we get good numbers, we may not get good number of quality embryos. So doesn't mean making good number of embryo oocytes or good number of embryos doesn't mean pregnancy. So we have to counsel at each and every point of time.
Thank you. I think that's very good and excellently expressed by all our panelists. We had a fantastic panel on maximizing ERT success. In the most difficult of patients, the PCO woman, which is very difficult to do. It teaches you a lot of things when you're stimulating PCO women. It gives you a lot of sleepless nights, but over a period of time, those of us who practiced in the GnRH agonist era before antagonists came know exactly what I'm speaking about, know exactly where I'm coming from. So now we have safer stimulation protocols, we have better strategies which are available, and of course, we are able to give much better clinical pregnancy rates and live birth rates to our women with a much better margin of safety, which is all important in today's world. Today, no patient or no couple is going to accept admission to an ICU because she went to a fertility clinic for treatment. The world has changed. Therefore, ladies and gentlemen, it's necessary to practice safe medicine first and foremost. Thank you, Dr. Jairani, for inviting me. Thank you, TNFOG and AMOGS for this opportunity. Thank you, all my wonderful panelists who are here and made my job so easy.
Thank you all.
Thank you,
sir.
Pratik.
Thank
Thank you
you.
so
Thank
much.
you, sir.
Thank you for this amazing and wonderful, panel. Really, everything is I really enjoyed, and I think you have cleared so many. Even the smallest doubts and smallest clarity, you have made it very clear about optimizing the success. Thank you. I have a great pleasure. We have all the TAPISA group of our fertility specialists here, who are the panelists here, right from Kundavi, Vani, Silabumaka, and Revati, Kukuresh, Raj. Everybody, I thank a lot. Kani, I thank every one of you. And a very special thanks to Revati and Sir who has joined. So everything was very much nice, and you have been very informative. And thank you, Pratik, for that wonderful panel. Thank you so much.
Thank you, ma'am. Good night.
Thank you.
Night, night. So I thank, on behalf of TNFOG and AMOGS, I thank the chief guest, Madam Sunita Madam, and the guest of honor, Dr. Jain Madam, Dr. Rajendra Singh, Vidya, Dr. Amay, and all my senior faculties, Dr. Pratik and Dr. Madan, for having this webinar in a great way. And I thank all TNFOG and AMOGS, all the delegates who have joined with us for your wonderful presence. Thank you so much. And a very special thanks to Sahiti, Rashid, and a very special thanks to Sri Priya and Anita Shri for coordinating. And a very special thanks, Madan, for joining hands to bring both the federations together. Thank you so much. Good night, everyone.